Well, this song is dedicated to the children of Africa. We're here to say that no child should be born with HIV in Africa. And if you believe with me, rise on your feet and let's sing together. Yo, 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 yo.
Attention. The future generation is here with us right now. And hear their voices. We have to stand and be.
Good afternoon, everyone. And really sorry for keeping you waiting. It's because we are real. That's why it's called real, because everything is real in our world. But good afternoon and thank you for joining us for our first Pata Real webinar for 2024. I'm Agnes Ronan and I'm going to be chairing this session for you today. I would like to invite you all to please introduce yourself in the chat box. We'd like to know who's here and where you're coming from, so please do that. And we also, just to let you know, we've got translation. So if you look on as you're facing your screen on your bottom right hand corner, you'll find screen for an icon for translation. So we've got French and Portuguese. So please do go ahead and select what you wish to listen in. And so thank you again. And as usual, I'll start with a quick reminder of what Pata Real webinars are all about. And for those who may be new to the platform. So this is a platform where we get to hear real clinical cases from the front line. So the acronym stands for reviewing of cases that some of you have found either challenging or interesting and feel that there might be something in that case for others to learn from your experience. And then the E is for engage, which means that hopefully we'll all get to engage on this platform. It gives us that opportunity, sharing some of the challenges in our different contexts. Beyond the presenters, you're also very welcome to share your experience in the chat box if something resonates with you. So please do feel free to use that. And A is for accessing expert advice. And that is when we get to hear from our panelists. We've got who I'll introduce to you in a minute. And they will each provide feedback to each of the cases that you will have presented. And that way, they will feedback to us in terms of what was done well with that case, what could have been done differently, but also what we've done well, because we all know that we're doing great work out there. So it's also nice to hear from the experts in terms of what we're doing well. And then obviously, we hope that we all learn something from this platform. There's something, at least something for us to take away. So that's the little bit of introduction for those of you who haven't been on this platform. And now I'd like to introduce our panelists. So here we have our panelists. So first of all, we have three presenters who will present cases from the field that they're prepared to share with us. I will introduce you, for now, I'm going to introduce you to the experts. And then for the presenters, I will introduce them to you as they come on the screen. So in terms of our experts, we've got 2 clinical experts and a psychologist, and many of you will be familiar with all of them, especially if you attended our summit last year. Our first panelist is Prof. Alani Sulaiman Akamu. He's from the College of Medicine, University of Lagos in Nigeria. And our second panelist is Dr. Nandita Sugari from WHO, and she's also a board member and part of the PATA advisory panel. And then our last, definitely by no means least, is Bahati Kasimonje. And Bahati is a very dedicated, you will hear if you haven't listened to her speak, dedicated mental health consultant specializing in pediatric and adolescent mental health. Bahati will engage with each of our presenters, reflecting on the psychosocial component of each case. So that's our clinical experts. As I said, I'll introduce the presenters as they come on board. So today's webinar is dedicated to advanced HIV disease. Those of you who attended our last PATA summit in November will remember that we had some really great cases on advanced HIV disease, and the feedback was that people wanted more. So therefore, by popular demand, we're back again with advanced HIV disease. And today we're spotlighting West Africa. We've got 3 cases, 1 from Cameroon and 2 from Nigeria. So yeah, brace up for what's to come. But before I introduce you to the presenters, we are going to do a quick poll, which you may have seen before, but it's just a test to see how much you've retained. And this is to just find out what your understanding of advanced HIV diseases. So the questions will pop up on the screen, and be ready to select your answers. And once you've all voted, I will then ask Dr. Nandita to step in and tell us how well we've done. I'm hoping we'll all do really well. And then we will then move to our presenters. So the questions, as you can see on the screen, the first question is, oh God, it's got a small, I can't see. Which of these children have advanced HIV disease? And you can tick as many as you like, or none, or whatever. So the first answer is, the first option is a 3-month-old with severe pneumonia and CD4 count of less than 25%. Is that advanced HIV disease? The second question is a 6-year-old growing well on 1+1Z score, CD4 of less than 30%, asymptomatic, diagnosed during PMT-CT visit. C is a 2-year-old with moderate malnutrition and CD4 of less than 25%. Our fourth case is a 7-year-old on ART, and that presents with sores around mouth ulcers around, yeah. And then the last case is a 10-year-old with TB. So the question is, which of those cases is advanced HIV disease? And so once you've done your voting, Dr. Nandita will step in to comment on your results, and then to give us a very brief intro of or a reminder of what advanced HIV disease is. So please go ahead and cast your votes. Okay, I'm not sure how we're doing tech. Do we have any results yet? Oh, there we go. Wow. Okay, Dr. Nandita, can I invite you to step in and maybe give a few remarks on or comments on the results, and then a brief overview of what advanced HIV disease is? Thank you.
Hi, everyone. Thanks, Agnes. And I apologize, for some reason, my camera is not turning on, but I am here live. And so I think those were those were some good questions. Now, technically, everybody under the age of 5 years is categorized as having advanced HIV disease by WHO. So, except for those that are over the age of 2 and stable on ART. So, that's kind of where our definitions currently are. But I do want to sort of point out that in these cases, we have, two younger infants, 3 months and 6 weeks. So technically, they would be advanced HIV disease just in terms of the terminology we use and the definition that we follow. And the 2-year-old, the 7-year-old, and the 10-year-old, if they're on ART, if they're doing well, then they may not be considered as advanced HIV disease. That's in particular for the 2-year-old. And for the 7 and 10-year-old, they may very well have AHD depending on their CD4 count or their clinical stage. But again, this is after the age of 5. We really stick to the adult definitions. And if I could just share my screen for a moment, I would like to sorry, I'm just trying to figure out how to share my screen because it's somehow not allowing me to do that. Okay, here we go. So I'm just going to share this for a moment, just to touch on a brief reminder of what advanced HIV disease is. So remember that advanced HIV disease was first identified or first really described in the 2016 or 2017 WHO guidelines. But we'll remember at that time, it was in 2016 that WHO had just published guidelines introducing test and treat. So that seems a long time ago, when these were the days before we would actually treat everybody. And we would wait until people were very ill and actually had what we now call the definition of AHD before we would start treatment. But as we started moving towards treat all, there was a recognition that people who were presenting for care had different needs. There were individuals who were clinically stable on ART. There were those that were returning to care or presenting who were still well. And there were those that were on ART who were failing, or those that were presenting or returning to care very ill with advanced HIV disease. So there really needed to be guidance on how quickly ART should be started with people with advanced HIV disease, and a real effort to better define the package of care aimed at reducing HIV-related morbidity and mortality. Now, where we fell with PEDS, the definition technically is that all children younger than 5 are considered to have AHD. And this, for the reason for this is because infants and children have an increased risk of disease progression and mortality compared to adolescents and adults. We know that even though children comprise a very small percentage of the overall population living with HIV, they disproportionately represent a lot of AIDS-related mortality. And at the time, the majority of young children were presenting with severe immunosuppression, and we still unfortunately see that today. And lastly, because we define AHD using CD4 count, many of us will remember that we use CD4 percentage to gauge immune status in children under the age of 5, not CD4 count. So again, using the adult definitions are slightly complicated by the unique issues that affect pediatrics. And so therefore, that definition sort of automatically came up to make sure that we remember that children who are younger than 5, who are living with HIV, are very vulnerable to illness and disease progression. When the issue came when we started using advanced HIV disease as a sort of label and as a categorization to determine who receives multi-month dispensing or spaced clinical appointments. Now, this became more urgent to consider during the COVID epidemic, and that's when we had to really make sure that we were clearly explaining what that definition for children really meant, and kind of what were some ways that we could explain this to make sure that those children who were stable could still be eligible for spaced clinical appointments and multi-month dispensing. So as much as we have the Stop AIDS package of care for all children younger than 5 considered to have advanced HIV disease, again, this is in recognition of the increased risk of disease progression and mortality. We also have to think about those interventions that are related to preventing HIV or treating HIV-related infections or opportunistic infections. But we also have to think about childhood, sort of regular childhood illnesses that may be more severe or advanced in children living with HIV. So again, our Stop AIDS package starts with screening for TB, malnutrition, and cryptococcal infection for adolescents in all children living with HIV, treating any active infections or active conditions such as severe acute malnutrition, optimizing antiretroviral treatment and counseling, and preventing against common infections with cotrimoxazole prophylaxis, TPT, and routine vaccinations. So with that, I'm just going to stop sharing and thank you very much, Agnes.
Thank you, Nandita. Yeah, and that was a really good overview to set us off. So now to the best part. And please, I remind you to ask questions, whether it's to Dr. Nandita from a presentation or from our presenters. Please just do post your questions in the chat box and say who is directed at. So our first case is being presented by Dr. Promise Okonyanyu from Gembu Center for HIV and AIDS Advocacy in Nigeria. After Dr. Promise is done, I'm going to invite Dr. Prof. Akamu to step in and give his remarks and comments in terms of how the case was managed clinically, any feedback, good, bad, what could be done better, and yeah. And then Bahati will come in and comment on the psychosocial aspect of the case. So the stage is yours, Dr. Promise. Please go ahead.
Good afternoon, team. So I'm Dr. Promise from Nigeria. I'm presenting the success story we have of a 12-year-old boy diagnosed of HIV in October 2013. His family circumstance was the son of a single mother cared by his grandmother in the village, which was later changed to our aunt in Gembu Metropolis with the help of clinic community collaboration. The child's disclosure status was fully disclosed. Child was fully disclosed. And the member of family living with HIV is the mother. The socioeconomic status of the child is low socioeconomic status. The child is schooling. He will just recommence school due to the free education given by the Taraba state government, and the child is currently in primary 4. He has been fully engaged into peer support group. The clinical presentation of the child. The child presented with oral thrush, with white patches on the tongue, inner cheeks, and scanty patches on the roof of the mouth. There is throat pain and discomfort of the throat, and slight difficulty in swallowing. On presentation, the child had fever and was febrile to touch with a temperature of 38.1 degrees centigrade. The child presented with loose stool of about 3 weeks duration, which is accompanied by lower abdominal pain and discomfort. There is persistent cough, which is worse at night, and yellowish phlegm and sputum with generalized body pains and weakness of the body. There was rashes on the face of the child and maculopapular rash all over the body, which has been recalcitrant to various antifungal creams and corticosteroid creams. When the child presented, we took the blood of the sample of the child and sent for full blood counts, erythrocyte sedimentation rates, malaria parasite test, crack test, gene spark test, and urinalysis. Then an urgent PCV was sent for. The PCV was very low, and this child was transfused 2 pints of blood. The full blood count came out, and there was neutrophilia and severe anemia. The MP came out, and it was 2 pluses, and there was protein in urine. The genotype results came out and there was MTB was not detected. There's no microbacterial tuberculosis. The medical intervention for this child that we did, he was transfused 2 pints of blood. He was dehydrated, so we gave IV fluid to rehydrate the child. We gave parenteral antibiotics because he was septic. We gave anti-malaria, IV anti-malaria drugs, followed by oral antibiotics, oral nystatins, and we improved the nutritional status of the child. This were all given to this child. So clinical evaluation and treatment history of the child. The child was diagnosed of HIV on 8 October 2013 and was initiated on antiretroviral therapy on 10th October 2013, 2 days later. The regimen initiated and the changes made was nevirapine. Then on 30th April 2021, the child was commenced on abacavir, lamivudine, and lopinavir and ritonavir combination. Then later on, the child was commenced on tenofovir, lamivudine, and dolutegravir. The viral load history of the child. As of 2021, the viral load of this child was 49,100 copies per mil. And in 2022 May, it was 22,011 copies per mil. In 2023 January, it was 3,700 copies per mil. Then when as of 2022, he was ill in 2022. So by 2023, we've changed the caregiver to the aunt who improved his nutritional status, ensured this child was being placed on drugs because the grandmother had little or no knowledge about ARV treatment, ART. So the aunt continued giving the ART. He was adherent on ART, and so the key challenges we faced are: 1, a 12-year-old child with advanced HIV disease living with a caregiver who does not fully understand anything about HIV, hence suboptimal access to care. Then a need to change the caregiver became imperative, but logistically challenging due to sociocultural value of the need for him to take care of his grandmother. There was also communication of the need for change of caregiver to relevant stakeholders was challenging without disclosure of the status of this child due to confidentiality. And there was recalcitrant generalized rashes despite declining viral load. So the lessons we learned from management of this child in this interesting case is there is a need to evaluate the capability of every caregiver before commencing a child or adolescent living with HIV on ARV. And there's also a need to reevaluate every caregiver even while the child is on ARV, because the caregiver might become nonchalant while the child is on ARVs. So the other lessons learned is the medical team should frequently counsel the children living with HIV and engage them in peer support group to ensure there is emotional and physical development needs of this child. Then sometimes the medical team cannot do it alone. As such, there's a need to collaborate with the clinics, with the community stakeholders, hence the clinic community collaboration. Thank you very much. So questions for the expert panel. The question we have is: 1, in such situations where the life of an adolescent is at risk and disclosure of status to third parties seems to be the only way out of that risk of consequent stigmatization, what is the best way to handle this situation without jeopardizing the patient's rights to confidentiality? Then question 2 we have is: what can I do as a health personnel, as a doctor, when the patient is presenting with viral suppression based on the viral load results, last viral load result we've seen, but still presenting clinically with challenges like presented body rash, as we saw in this 12-year-old child? Thank you very much, Tim Pata. And thank you, everyone.
Sorry, thank you so much, Dr. Promise. In the interest of time, I'm going to hand this over to Prof. Alani. If you could please speak to Dr. Promise's case and give your provide your inputs and especially in response to some of his questions. And then after that, if Bahati, you could then come in and comment on the psychosocial care of this child, which there's quite a lot going on. So over to you, Prof. Alani.
Thank you for having me to join this webinar. This case, I think, to me, is very straightforward. This individual has not received the best of care, and I'm going to leave the socio-cultural aspects of this to the expert to handle. What I would like to comment on this child is that the definition of AHD does not come out properly, but in the case presentation, it actually came out. WHO defines AHD as presence of severe immunodeficiency with CD4 cell count less than 200, or this individual has WHO stage 3 or 4 disease. That individual has AHD. We do not have CD4 cell count of any sort in this individual, but that he had thrush and had sore throat and painful swallowing would tell us that that individual also has what we would call esophageal candidiasis, and that's a stage 4 defining disease. This individual also has a stage 4 defining disease, which we call HIV wasting syndrome, consisting of the triad of chronic diarrhea, that is number 1, number 2, fever, and number 3, loss of weight. That is HIV wasting syndrome. So looking at that syndrome, from the definition that we have from WHO, this child actually suffered advanced HIV disease. Now, this child was said to be on antiretroviral therapy. You are on antiviral therapy, you are not supposed to have depressed immunity, not to talk of having AHD. The point that this case is also emphasizing is that the fact that an individual is on antiviral therapy does not exclude you from coming down with advanced HIV disease, particularly in the scenario where an individual does not receive optimal care, adherence is horrible, social-cultural background is terrible. And this is what I've seen in this individual, and I probably will wait and see what the social expert in the panel is going to talk about. But the question that the number 2 question, an individual has become virally suppressed, and I want to thank the team that managed. You are able to bring the viral load from about 49,000 to undetectable. That is fantastic. I'm happy with that. But your question is, virological suppression has been achieved, but some clinical challenges still persist, particularly generalized body rash. This is an individual that is living where I think he's living. Number 1, we want to look at, we want to exclude what we call viral cutaneous diseases. Viral cutaneous disease is very unlikely in this individual because the type of rash that you describe doesn't sound viral. And the common virus that we think affect the skin in the setting of severe immunosuppression is herpes simplex and herpes zoster, and they are characteristically very painful cutaneous diseases. So I don't think that's what that child has. But we have other diseases, viral diseases. We don't even know the etiology in full. What they call molluscum contagiosum, which is a kind of a viral illness that only goes by itself after a prolonged period of time or when immunity are sufficiently recovered. So viral illnesses is there. But this individual can also have TB of the skin, can have fungal disease of the skin, and the way to get out of the cold room is skin biopsy. We just biopsy that skin and we'll get the answer. If it is a collagen disease, we will know. If it is a drug reaction, we will know. If it is actually as if it's a non-infectious, skin that this individual has. So the ultimate, when we are not able, but always think of viral cutaneous diseases, we are not getting that. Remember, you can have cutaneous TB, you can equally have fungal cutaneous illnesses, and these are very difficult to treat, and they don't even go away. I'm surprised that you said you did expert TB and it is negative. It will be negative if that individual does not have pulmonary TB, but this individual could have extra pulmonary TB, and your expert TB does not give you the diagnosis. I hope you remember that you can actually check the urine today to close the diagnosis of TB, because we are now able to look at product of microtubercle bacilli in the urine, and we are able to tell you that TB is there. I suspect with this kind of an individual, for the type of standard of that he is having, I will not rule out extra pulmonary TB. You have succeeded in getting the viral load to undetectable level. Kudos to you. For that skin, I'm still suspicious that it may be a chronic bacterial cutaneous disease or a fungal disease. Over.
Thank you, Prof.
Thank you for your presentation, Doctor.
Oh, okay, go ahead.
Thank you for your presentation. I quite liked your key message around looking at the caregivers once we're considering starting art. I think often we think of art commencement as, do we have DTG, or do we have the treatment regimen? Did we do the adherence counseling and tick those boxes without looking at the care that is supposed to be surrounding the young person who is starting art, or whoever it is that is starting art? So I really liked that key message. And as you were presenting, I was thinking, let's look a bit into this young person's life, and let's look at him holistically beyond the advanced HIV disease. So this is a young man who is living in a household where he's changing caregivers. And that's something that we need to be thinking about, that how is he interpreting this change in caregivers? How is he interpreting his social connections and his family environment? Because at that age, remember, he's 12, so he's pre-puberty, going through puberty. There are lots of changes cognitively, emotionally, physically. He's dealing with a lot of change, and there are a lot of changes in his social environment. So what kind of support are we offering him in addition to his medical treatment? You've mentioned that he's been disclosed to fully. I wondered what that meant. Is it just the traditional full disclosure of you are naming the illness that a person is living with and the treatment plan and the modalities? Or are we really thinking holistically at looking at what does disclosure do to this young person? Are we doing post-disclosure sessions, or is it just we've done the disclosure, it's a tick box and that's it? Or are we considering the aftercare for the full disclosure, which would then also involve the families? How is the family coping when we do post-disclosure support? How is the family coping with the treatment, with any emotional or mental health needs that could be arising, any social health needs that could be arising? Assessing for those things, and not just doing the pill counts and checking the viral load, but our disclosure also needs to incorporate post-disclosure support. This is also a young man. When we look at him, you said that he stopped school for a while. What did that do for him? Starting school late, knowing that there are limited financial resources, how did that impact on his psychological well-being, on his social well-being? Being behind in school, your body is frail. What was that like for him? How was he experiencing this aspect of the advanced HIV disease in his educational environment? We also need to be looking at his mental health. So we are aware that sometimes when people are ill, they face anxiety symptoms around their prognosis. Am I going to get better? And this is something that is continuing and is ongoing. Despite his viral suppression, he still knows that I'm unwell. And often the message that we give is once you take your art, you're going to be well. But in his case, he's noticing that, okay, I have been making efforts in taking art, but I'm still unwell. Was there any anxiety about his prognosis? Are there any depressive symptoms associated with being constantly ill or with the pain that comes with being ill? His body is also going through changes, and this is a young man, so he's got a rash. What is that doing to him? In terms of social stigma, perhaps sometimes people want to stay away from people when they don't understand what's going on with their bodies. Sometimes a person can even withdraw. If you're coughing a lot, you feel like maybe I should keep my distance from people so I don't infect them. And so there's that social isolation that we need to be considering, especially with people who are feeling quite frail and ill. And so we do need to be thinking holistically about a young person who is going through advanced HIV disease. And I'm hoping that these are a few pointers that we can start looking into when we think of how we can give holistic and comprehensive care for our young people. And I think one of your questions was around how do we then handle disclosure to third parties? I think a key aspect is building trust and establishing rapport. We sometimes can minimize it and look for, I don't know, therapeutic techniques, which are good. But I think the foundation of building trust and establishing rapport, even with the young person, helping them to understand their treatment, helping them to understand your role, and then asking for their assent. He's 12, he can verbally assent and participate in a collaborative treatment approach of who are your trusted people. Let's find who is your social support. Who are the people that you could trust with this information that could help us in this regard? So I think a key thing is establishing rapport and getting assent from this young person. I think it's also important to have like family conferences or family therapy sessions for the whole family to understand what is going on with treatment and what could be strategies that the family could institute, whether in the home or clinically from the facility. What can we do to help this young person? How can we form a strong circle of support for this young person? I think it's also important to understand any root causes that could be happening in the family dynamics that could be leading to the change in caregivers. You mentioned that his mom is single. Do we know anything about the paternal side? Are there any issues there that we need to be considering and looking at? Are these issues for him as well as a young man? So really trying to explore from the roots what's going on in the family from a collaborative approach of how can we support this young man and who can we seek support from so that we can try and get consent for example, if we need to talk to the aunt to care for him, if we need to talk to a different relative to get his support and to get his also ideas and thoughts of who are his ideal social support systems. Thanks.
Thank you. Thanks so much, Bahati. And I mean, it just goes to show, like we say, just testing, treating, linking to care and adherence is not the end of the story. And quite often we're quite relieved when our clients are suppressed. But there's so much more going on, especially in the life of adolescents. So thank you, Bahati. Without wasting time, I'll move on to our next presenter. And that's Dr. Abdulrahman Fofi from Government House Clinic in Jalingo, Nigeria. And Dr. Fofi, would you like to take the podium and present your case? And then after that, Dr. Sugadi, can I ask you to step in and comment on Dr. Fofi's case? Thank you.
Thank you, Agnes. I'm so grateful to be here. I'm Abdurrahman Fofi, as you said earlier. I'll be presenting a 13-year-old female who was diagnosed with HIV in 2011. She's the second of two children to a single mother who also lives with HIV. Our elder sister, who is 15 years old, is with HIV, but for some reasons has declined taking medication despite all our efforts in counseling her to do the needful. She knows her status. She's fully disclosed to the members of our family living with HIV are herself, her elder sister, and her mother. Her mother, who is a small-scale farmer, is her only source of support. She was in primary 4, a class which is not appropriate for her age, and that is because of she has often been off and on school as a result of ill health. She is a member of the youth-friendly team at the facility and Operation 000 Club, also at the facility. Her mother has been fully responsible for her care. This girl was transferred from Taraba State Specialist Hospital 11 years ago, where she was diagnosed 2 years earlier and initiated on treatment. She was initiated on zidovudine, amivudine, and nevirapine with a baseline CD4 percentage of 15% and a WHO stage 2. Her medication was later changed to abacavir, lamivudine, dolutegravir in 2021. That is in my current facility. Her first viral load was 655,000 copies per mil in 2021. Second viral load was 20 copies per mil in 2022, and our third viral load was 65 copies per mil in 2023. Perhaps you'll be wondering why we do not have records of viral loads from 2011. Records show that she has been very consistent with her CD4 count. Which has daily 2024 401 cells per microliter, or by 2017 she had up to 1,199 cells per microliter of CD4 count. So she has been very consistent with her CD4 count. And perhaps reason for not having viral load then was because viral load was being paid out of pocket and not supported as it is now. Thank you. Then this table shows the drug she has been on, and staging and the viral loads, as you can see, well improved on as we changed their treatment. Next slide, please. Prior to the onset of symptoms, she defaulted on her medication for 9 months and later presented at the facility with symptoms of cough, fever, and difficulty breathing, and was managed for acute respiratory tract infection. Note that at that time when she presented, we did a GeneSpark result, which showed that MTT was not detected. The client responded well to antibiotic treatment and was placed on Cetrin. In 2022, when she was 12 years old, she had full disclosure of her status and enrolled into youth-friendly weekend program. During the youth-friendly program in the facility, she confided in one of the facilitators that she had been defaulting on her medication. She was subsequently counseled and followed up. She, however, presented 2 months later with complaints of sores on the head, patches on the face, widespread maculopapular rashes, and cough. On examination, she was chronically ill-looking, not in respiratory distress, with pale brown hairs, not pale and afebrile. We did a GeneSpark again. We did a TB LAM, both of which were negative. She was then placed on medications for systemic mycosis, enrolled on ESC, and referred to orphans and vulnerable children program for support. She then presented 5 months later with similar complaints. A chest X-ray was done, which was in keeping with pulmonary tuberculosis. On account of the above, she was referred to another facility to be enrolled in pediatric anticox. She took anticox for 2 weeks and got some improvements. On the 3rd week, her health depreciated and was self-referred to a tertiary facility where she spent 5 days on admission, and sadly, she passed away. So what are our key challenges we notice in managing this patient? A challenge of ensuring adherence with medication. Vis-a-vis the thought that her elder sister, not being on HAART, might have influenced her defaulting on medication. That's one of the challenges we had, convincing her, since obviously she could see that her elder sister was not on medication and she was not as sickly as she was. Our key lessons learned here is that In looking at every child, every child that presents at the facility, we must look at them holistically, and that is why we saw that it was at the youth-friendly activity that we could detect that she wasn't defaulting on her medication, and we had to refer her to orphans and vulnerable children program for financial support and other support. So we learned that to look at these children is not just about the ART, we must look at them holistically, and that affects every aspect of their lives. So the questions for the expert panel is, in the case under review, the result of investigations for pulmonary tuberculosis using GeneSPAT, TB LAMP were negative. Take note that this patient was already on Septrin and also at some point placed on fluconazole for systemic mycosis. While the chest H2 and clinical assessment were in agreement with tuberculosis. With these conflicting findings, what is the best and standard approach for handling such cases, especially in resource-constrained settings like ours, where a client of this or a patient of this financial background will not be able to afford some of the further investigations we would have loved to do. So thank you so much.
Dr. Fofi, Dr. Nandita, would you like to step in?
Sure. Thank you so much for that case. This was a complicated case, and sadly, this is a story we hear very often. You know, we also, you know, we often talk about young children or infants who are vulnerable to advanced HIV disease, but we also see this quite frequently in adolescents, and especially in cases like this where there are issues with adherence. I do want to just compliment the team on putting together a really great case. Again, it sounds like this is a child who has been in care for quite a while. So she was diagnosed in 2011. And, you know, though though we now know that AZT3/Tc nevirapine is not the most optimal regimen, it actually did maintain her until 2021 when she was finally switched to abacavir, lamivudine, and dolutegravir. And this, she may have been failing looking at the viral loads. It looks like she may have had treatment failure while she was on her first regimen. So likely she had developed resistance, and switching to an optimized regimen with abacavir and dolutegravir in it is somewhat of a second line for her, but at the same time, you know, again, is now the standard treatment regimen for most children and adolescents and adults living with HIV. We know from her CD4 count that she actually had good immune restoration. So her CD4 count was well above normal. So it did not look like she had, you know, when we were following her CD4 counts, it looked for a long time that she was well. Now, I want to point out here that as we've increased coverage with viral load, we've dropped back on checking CD4s. And I think we've kind of started to forget that CD4 can still really be helpful in identifying immunosuppression, and is still essential in identifying advanced HIV disease in all adults, adolescents, and children older than 5 years. I also want to point out that I think it was not until 2022 that she was fully disclosed to. And so this must have been when she was 13 or 14 years old, or 13 or 14 years old, if I'm doing my math correctly. But I do want to also say that this is late disclosure. And I'm curious what her understanding of HIV was. Bahati mentioned earlier, it's important that disclosure is followed on with ongoing conversations and follow-up to make sure that there is an appropriate understanding of HIV. But I just want to question the team a little bit in thinking about what she may have understood before formal disclosure, particularly since she has a mother and an older sister who is also living with HIV. And I absolutely agree that, the fact that her sister is non-adherent to her ARVs is concerning, and absolutely that may give her sort of the impression or influence her own decisions. But I will say that, again, I applaud sort of the team in recognizing the importance of psychosocial support and peer support, and having her join in in the peer support groups. Now, that said, this case also illustrates the importance of making sure we are going to the best source for information about what is happening with our clients. And in this case, I think it really brings out that the importance of peer support or peer groups and psychosocial support, and also making that connection where she felt comfortable, where she felt that she could entrust the person she spoke with information about her adherence issues and her adherence challenges. So I think that in some sense, although this is a tragic case and sadly ended in her death, that we can learn from this in terms of following adherence over time, making sure that we are also empowering peers, counselors, and those that are interacting with our clients to identify when there is a problem and take action for that, because oftentimes they are the ones who will see or hear things long before the clinicians do. So I think that was a very illustrative. And lastly, I want to just comment on the testing for TB. So I'm not sure what her CD4 count was at the time of her illness, because again, very often we've stopped checking CD4 count routinely, and we know that if people are stable on their treatment with immune restoration and a suppressed viral load, that as long as they are stable with a suppressed viral load, we do not anticipate the CD4 count to drop any lower. So we tend to stop monitoring it after a time. But I think with advanced HIV disease and more attention to this area, we're realizing that we may have let go of that too prematurely. And in fact, CD4 can still provide us with sort of more information about immune status, and particularly around rapid decline in immune status, as well as happened with this case. I also want to point out that the tests that we use are not infallible. So Gene Expert is definitely a very sensitive and specific test for the most part, but still not 100%. And when we look at TB-LAM as well, TB-LAM can be used more reliably at a lower CD4 count. So we find more reliable results when the CD4 count is actually less than 200 in severely ill patients, or less than 100 in those that are being seen in an outpatient setting. So even though the Gene Expert and the TB-LAM tests were negative, I appreciate that the team went ahead with the chest X-ray and clinical assessment, because very often we do have to put a lot of these different diagnostic pieces together when we are assessing for tuberculosis. This is again a challenging diagnosis in children. One question I wanted to raise is also about her history of TPT. So again, we have recommended now that all children living with HIV complete at least one course of TPT. And while this has been, it sometimes can be challenging, but this has been 6 months of INH at the time of starting after diagnosis, though we do have now some shorter course TPT regimens that are available for adults and should be available for adolescents and younger children shortly. So I want to bring up that we again have to think about some of the prevention issues when we think about advanced HIV disease and preventing mortality. And lastly, following her death, again, sadly, this is too often we hear of deaths that occur even after just it seemed like she had some improvement after being hospitalized and starting on treatment. But again, we need to look into what happened there in the hospital. And I think this is really a rationale for focusing more on inpatient care of advanced HIV disease, to make sure that we are managing, as we know there are often a complex combination of different infections that are going on that need to be managed. And last of all, I want to come back to the family, and I'm curious what Bahati's thoughts are on this. But it really, I would think, and I would hope that, after this experience, this would be a motivating factor for her sister to also not become ill. But I would really question sort of the mental health or the psychological state of her older sister, who has seen her younger sibling at this point really suffer from advanced HIV disease and TB and ultimately pass away. So this is an opportunity to engage with her as well, and hopefully we could prevent the same thing from happening. So those are just a few thoughts from my side, but I'm happy to turn over and hear from my colleagues as well.
Thank you, Dr. Nindita. I think you raised an important point with regards to the family after the loss of their daughter and their sibling. And whether I think they should be in care in the same with the mom. That have they had any grief counseling? Has their thoughts around medication been explored post-grief? As healthcare providers, I think because our primary aim is to get everybody on treatment, to get everybody well. Our assumption can be that this is going to motivate the family to adhere or to start medication. But sometimes it actually can be a deterrent, and which is why the value of sitting down and exploring with the mom and the sister how they are processing this young girl's death. I've had cases where a person will say they took medication and it still didn't help them. So what's the point? So it can be a demotivating aspect, but it also can be a motivating way of then getting people on treatment. But it's important that we actually explore and sit down with the family and not assume what we would think, maybe this would work for me, or surely this will get them into care. But just to at least touch base with the grief. When we touch base on a human level, not just our sort of professional level of we want them to be on treatment, we can achieve more. So I think it would be an important point to explore how the family is handling this young girl's death, and what would that mean in terms of their own health? How are they interpreting that? But just to circle back to peer support, I think it's a very important point that peer support is an essential in HIV care, in any health care. But I think in HIV care, it has been shown that peer support creates a community, a sense of belonging, a sense of camaraderie where you are together with people who understand some of the aspects that you've been going through, who are also facing similar challenges or strengths that you can glean on, that you can lean on and use for your own well-being. I think it's important as healthcare providers to view peer support as essential and not a nice to have, because when we have that mindset shift from this is just who they're waiting, or young people have at least something to do whilst they're at the clinic, whilst they wait for the real service, we then don't invest in the peer supporters, we don't invest in the service, and we don't invest in creating spaces, these spaces that are crucial for young people to be able to have a sense of belonging and express themselves freely. So our mindset shift of peer support being essential, I think, is quite important, because it helps us in investing in those spaces and the cadres who work in those spaces. So it's good that this young girl had that space. It's good that she had people that she could share these aspects with. I think it's important, I think Nandita alluded to it, where she says, but when things are brought up from the peer spaces, how is then that actioned? What is the treatment follow-up for that? So I also wondered, what was her enhanced adherence counseling like? Was it the traditional enhanced adherence counseling of sticking to what is a viral load, what is HIV, what does your medication do, what is a CD4 count, or did it explore other aspects of this young girl's life? What is it like for her to be on treatment whilst her sister wasn't on treatment? What was it like for her to stop going to school because of the illness? What is it like for her to be living with a chronic illness? Can we incorporate these discussions in our adherence counseling so we get a better understanding of the people sitting in front of us? Because it's not just about the pill count, it's not just about an undetectable viral load, but it's about a whole being. And to understand them helps us get to our clinical management goals of, yes, we want to suppress viral load, but the road that we need to travel to get there is often getting to know the other aspects of that person. So I did wonder, what was the enhanced adherence counseling and what was her understanding of HIV? Did she feel that people just focused maybe on the presentation of HIV, or was there a holistic approach to what she was going through? But I think your point with regards to peer support being a safe space that we should invest in, that we should view as integral to clinical care is essential. Thanks, Agnes.
Thanks, Bahati. And yeah, and I think the team, as we prepared this case, is really grappled with this case. And really thinking like in 2024, no child should be dying of HIV. And I mean, it's really terrible when you hear the clinical staff have done as much as they can. They've done all the tests, and still, yet we're still struggling to prevent deaths in young people. And I think, and children, and I think, what Bahati is unveiling, that there's also so much more we can draw from outside the clinical space. So maybe for me, there's lots of takeaway lessons in that. So I would like to move on to our case number 3, which is being presented by Vera Yansila from Cameroon Regional Hospital, Baminda in Cameroon. Over to you, Vera. Sorry, I know we're kind of squeezed for time, but I'm going to ask you to go through your presentation, and then Prof. Falani, if you could, give quick remarks after that, and then Bahati, and then, thank you.
Good afternoon, everyone. Okay, I am Vera, presenting from Regional Hospital Bamenda in Cameroon. Okay. We are looking at a 16-year-old male diagnosed in 2021, born to an HIV-positive mother. This case is being managed for a severe bacterial infection, which is osteomyelitis. Child has been disclosed to as the mother has warned. Child hasn't been disclosed to as the mother has warned against it, saying that she is not ready to tell him, and the child has some cognitive developmental delays. Why do we say this child has some cognitive developmental delays? Is because this child is in a class way below his age, and the child does not behave like children of his age, and equally doesn't even respond like children of his age. The mother is positive and was diagnosed in 2008, same year this child was born, and said to have started treatment in 2014. No prophylaxis given to the child at birth, as reported by the mother. Child has had multiple hospitalizations prior to his diagnosis. However, his ART history prior to that is unknown, as mother does not disclose any, and when asked, the mother has refused disclosing her status and that of her son to the husband as well. Now, this child goes to school but has cognitive developmental delays. The father keeps asking to know what is wrong with the son, as he is in and out of the hospital frequently, but the mother still does not want him knowing anything about his HIV status. She claims to have help to the healthcare providers that this child takes his medications well, and is just convinced that the medications are not right for the son, as she does not even encourage this child to take medications as prescribed, and neither does she even supervise when this child is taking medication. Next slide, please. Okay, on the clinical presentation, that's in 2021, upon initiation, this child was initiated on Abacalam 600 and DTG 50. And in 2021, that's 6 months after this medication is in December, still on the same regimen, this child was tested for viral load, which was not detectable. A year later, still on the same regimen, this child was collected for viral load, and the results came back 46,108 copies. This child was enrolled on EAC, did EAC for 3 months, which was not satisfactory, was again extended for 3 more months, where this child was collected again in July 2023, which the copies came back 942,201 copies. Now this child was switched to second line. Switching this child to second line because it's on the algorithm, and plus with the notion too that this mother didn't even believe that the previous regimen was actually working for this child, and the child now was now switched to Tenolam Atazanavir, which is second line. Next slide, please. Now, this child was presented in December 2022 with a painful right leg. The diagnosis of osteomyelitis on an existing condition of severe malnutrition was made. Child admitted in the hospital severally. Antibiotics were given, but follow-up not complete, and the mother never even complies to follow through the course of this child's hospitalization period. X-ray was requested, but not done, as mother claims to be very busy. A full blood count showed anemia, for which this child was transfused twice. The caseworkers have severally supported to bring the child to the hospital and even supported with the cost of treatment. But still, the mother was still proving difficult. Now, looking at the key challenges we faced with this child, the issue of non-disclosure to the child, which hinders him from taking drugs correctly, hence worsening his advanced disease state. The non-disclosure to the father, which makes it hard for the child to take medications, as he can't take drugs when father is at home. The child never comes in person for ART pickup because the mother fears being stigmatized and not sure of the father's reaction, so clinical follow-up is not comprehensive. The follow-up of the osteomyelitis is poor, as the mother does not readily bring the child for follow-up and keeps claiming that she does not have time. The CD4 count reagents are not available as at now, which is also difficult for us to have the child's CD4 count. The status of the father not known, despite several efforts made by the service providers to get to him to the facility for an HIV test. Now, what did we learn from this case? We cannot provide holistic care when one parent is not aware of the status, and the lack of disclosure either to the child or the partner makes it difficult to provide quality care. Now, what we want to know is, apart from switching the ARVs to second line, which was done recently, what else can help slow the progress of the osteomyelitis in this adolescent? And what actions can be taken to compel this mother to follow up the child's treatment? Thank you, and over.
Thank you so much. Thanks, Vera. We'll pass this one on to Prof. Akan Alani. Please go ahead.
Thank you very much, and I thank this presenter for very lucid presentation. Please just permit me to run little commentary on this patient, whose major problem included: one, osteomyelitis that is not going to heal; two, neurocognitive impairment. I think these are major issues. And of course, eventually you failed the first line and you have to switch to second line, and I have issues with your decision on that. Now, the neurocognitive impairment, I think this child is entitled to that serious neurological complications, because we know that this virus, there are the neurotropic form. It probably has that neurotropic form of HIV, what they call the HAR4 type of viruses, or HAR5 type of viruses. Now, we also understand the mechanism by which HIV gets itself across the blood-brain barrier, what they call the Trojan horse mechanism that gets the HIV into the neuroglial cells. And that child, unfortunately, if an individual develops what we call HIV-associated neurocognitive development, reversal is a bit challenging. I'm sorry, you actually need the support of neurologists to help him out. And of course, a special education requirement may have to be applicable to him. That is that. Now, as for the non-adherence to antiviral therapy, I will leave that one to our social expert in the house. Non-adherence has led to failure of his regimen, and the regimen and the viral load has just jumped up to a whopping value of close to 1 million copies per mil of plasma. And we think if we switch that individual to second-line regimen, is the best for him. It may not be the best for that individual. Why I'm saying this is that when you see very high viral load, it's very unlikely that this individual actually has mutant viruses. We say HIV mutant viruses are actually wounded viruses, viruses that have acquired HIV drug resistant mutations, lack capacity to multiply very fast. When an individual has accumulated a lot of drug resistant mutations, you will find viral load 8,000, 10,000, 3,000. When you find viral load 600,000, 500,000, those viruses are more likely to be wild type virus. The wild type virus have the capacity to multiply very rapidly. The mutant viruses have lost the capacity to multiply very rapidly. So we may have switched this individual prematurely to a second-line regimen. If I were to be in charge, all I needed to do with this heavy viremia is to ensure that adherence is achieved. If it will mean you practice what they call DOT, like you do for TB, that your first drug will still work. Because if you send this individual sample for HIV drug resistant, everything will be returned to you susceptible. And we may have actually exposed the individual to the second line that he does not actually need. The funny thing is that this presentation appears to be incomplete because after you have now switched to what came off the now around 42,000 viral load, it may have come down seriously because they are susceptible viruses, but it doesn't mean that if you had continued on what you think is failed regimen, you wouldn't have achieved the same. I just want us to ensure, I just want us to bear this in mind, that next time, remember, every viremia implies presence of wild type virus. Low-level viremia in the presence of drugs imply large number of mutant viruses. I think the major issue in this individual is not about the drug working or the drug not working. The major issue about this individual is psychosocial. And I think if we are able to answer your question, what can we do to really compel this mother to agree to disclosure, everything is likely going to change. And I think that the expert be done. How can this woman be canceled? Does this woman actually herself require an assessment by a psychologist or by a psychiatrist, or does he have a depressive illness that has to be managed for us to be able to get through her and allow the right thing to be done? Over.
Thank you, Prof. And that was going to be my first point, that I think before we try and look for the strategy, let's look at the mom. Let's explore what's going on with her in terms of her own cognition and her own mental health needs. I think an assessment is necessary for the mom, but not just referring her from a punitive point of view that you're refusing to listen to us as the healthcare providers, but from a supportive, let's also give you a space to work through being a caregiver who is not supported because she doesn't have a husband's support, because he's also unaware. She's also has a son with special needs, and sometimes the cultural and social stigma around that can be heavy. So I think a psychiatric assessment or a psychological assessment that comes from a supportive space would help for us to understand whether mom is also okay, or whether she needs support, and whether she has any underlying conditions or issues that are affecting her functioning, as well as then impacting on her child's well-being. I think it's also important that there is a multidisciplinary team approach to this. It can be complex for one person to be making decisions about the care of this young man, and to say, okay, how do we get the mom to come in, or what do I do now? And I think that is the beauty of working in a MDT team, where you can involve even the legal professionals to understand, is this a child protection issue now? Is this an issue where there is neglect? You mentioned that the mom does not assist with adherence, or sometimes does not bring him to the appointment. Are these areas of neglect that you can converse with a social worker, for example, a social welfare system? Again, not from a punitive aspect, but in the best interest of this 16-year-old young man and of the family. I think it would also be wise to question the legal fraternity about the paternal rights to knowing of their child's medical condition, because there could be a caregiver that you could utilize, a family resource that you could utilize, but he is unaware. And what are his rights pertaining to knowing the diagnosis of his child and the care of his child? Often the default carers are the moms, but fathers also have rights that we need to recognize as healthcare providers, and to explore together with the mom what are the family dynamics that are hindering her to disclose? Was there stigma related to having a child with special needs or any neurocognitive issues, and then thinking that an additional diagnosis is just too overwhelming? Is it just a case where she needs support and psychoeducation around these aspects? Is there some sort of abuse going on? What is going on? Or is there an underlying mental health condition? So I think a more holistic, thorough assessment that involves a psychiatrist, a psychologist, a social worker, if there are any community legal resources that we could tap in. I think sometimes we also focus on people coming to the facility. There is value in us going into the community. And so I would recommend a home visit if you notice that your efforts to get the mom to come to the clinic or dad to come to the clinic are not as fruitful. If there is consent, or if that is part of your treatment management, when people come into care, taking resources for this, I think, would be beneficial, to go into the home and see what's happening in the home, or to engage with the father at the place that he is at, with the mom where she is at, to make it more convenient for our clients. I think we then also do need to really holistically think, what is in the best interest of this young man? Are they, again, child protection issues that we need to consider, that do not have to lie solely on the healthcare provider? We can always engage and ask for the expertise of other professionals on, what does the law say about this? What does the Children's Act in your country say about this? How can we help this family? What does a psychiatric assessment, what will that yield for us in terms of caring for the family? And again, I really do emphasize that it's not coming from a punitive stance, because already with mental health, there is huge stigma. It seems as if you're now sentencing people to more stigma when you say, let's go for a psychiatric assessment. But demystifying it and explaining the reasons behind, we want to see whether this is going to help your family, whether we need to explore for your own support, for your own care. Whilst we've been focusing on your son, but we also realize that for you to care for your son, you also need support. Something like that, phrasing it in a very supportive manner, I think would help this young man. Whilst he is our index client, we do need to then look at how can we support this family holistically. So just to summarize, I think an assessment for the mom would be crucial. I also think an assessment, a home visit for the family, particularly going to the father. I think an MDT approach is crucial in this aspect, working with social workers or a social welfare system in your community, any legal fraternity or people that we could inquire from in terms of rights and the way to go about if this is a child protection issue, as well as then looking at, okay, fine, once we have these things in place, what is in the best interest of this young man? What is the best interest of this family? Thanks, Agnes.
Excellent. Thank you, Bahati, for that very comprehensive summary of what we need to be thinking about. What I can say is, I did like your idea of bringing in the multidisciplinary team, and for us as facility teams to understand what resources are available in our community. Sometimes we're not always aware. But what I also understand and hear is not many of us have these resources in our communities, whether it's social welfare system. So, these platforms, a lot of what, you've raised earlier, Bahati, about peer support, about family support, we can also draw from our communities and from our social support systems to support our young people. So lots to take away. And what I would really like to do is just to go from each of the panelists. My mind is blown. I'm trying to think what was the best takeaway, but there were lots. So I'm going to ask each of the experts to just give us one quick takeaway from what we've discussed today in terms of supporting healthcare frontline healthcare teams as they try to support children and young people amidst shortages of resources, amidst very busy clinics, amidst not having enough history from families. What would your key takeaway be to health providers that they can walk away with from today's discussions? Maybe I'll start with, can I start with Prof. Akam, then Bahati, and then Nandita, if you could wrap it up for us at the end.
Am I starting? Thank you very much. Just one quick thing about that third case. What do you do to get osteomyelitis out of way for this individual? That patient must be referred to orthopedic surgeon to do what they call a debridement. They have to debride and remove all the dead bone before you think any antibiotics is going to work. I forgot to mention that. So that is that. Now, my takeaway has to do with that presentation of the second patient. That patient died of classic immune reconstitution inflammatory syndrome. Please, everybody must remember this, that there are 5 major AHD killer disease. On top of the list is tuberculosis. Next to it is cryptococcal meningitis. Next to it is cerebral toxoplasmosis. Next to it is pneumocystis pneumonia, and next to that is bacterial sepsis. That second patient had undiagnosed TB. At the worst of cases, if you have chest X-ray suspicion, it is enough to start anti-TB regimen. Please do not say your gene expert was negative, TB lamb was, there can be lab errors. If you have strong clinical suspicion, even if the chest X-ray is not indicating so, your clinical suspicion is indication for initiation of therapy. But remember, they started treating this individual, and the next 5 days or so, he died. Meaning that managing these killer diseases in the setting of HIV infection, you must, in the setting of AHD, you must obey the rule. Obey the rule means that you must institute anti-inflammatory agent, or you withdraw the antiretroviral drug. Otherwise, you will set up severe inflammation that is going to kill that child. Please remember, you can start TB treatment on suspicion alone. Don't say this is not there, this is not there, this is not there. It is not correct to assume so. And you can, and when you want to start, please remember that you must obey the rule. And the rule is that you're starting antiretroviral therapy with effective treatment for TB can kill that individual. So one has to wait for the other. But we are not going to wait, and the patient has been on antiviral therapy for long. You must at the same time institute effective anti-inflammatory agent. Thank you.
I think as frontline workers, let us not work in isolation. Let us lean on each other's wisdom, expertise, and get the support that we need so that we are not managing people in isolation and feeling like we have to have all the answers by ourselves. And I think it's important as healthcare workers that we take care of ourselves. And then finally, I think we need to really start thinking of the people that we work with comprehensively and holistically, and not just looking at one aspect of their lives. Thanks, Agnes.
Thanks, Bahati. Nandita, please go ahead.
Sure, and I'll just keep this short. And again, thank you so much to the presenters for putting together these really great cases that illustrate, I think this really illustrates the reality on the ground that many of us still see today. So a few takeaways is that we do have new regimens that we say are optimal, and we've seen great advances in the rates of viral suppression with the rollout of dolutegravir. But this in itself, as much as we call that a game changer, has not changed everything. And so we still have to think about those issues related to stigma and self-stigma in particular, as well as issues related to adolescence, adherence, and disclosure. And so I want to echo what Bahati has shared, is that just thinking beyond and going beyond our own specific expertise to work together as a team of healthcare professionals, as we are seeing now that these children, as they are growing up, they are still, as much as we focus on, the deaths in the younger children, we are also seeing in adolescence this increasing mortality as as some of these issues around stigma, around non-adherence start to kick in. And so again, this is a reminder that we can't just take the simple solution out, but that we really have to pay close attention to both the clinical details and the psychosocial details if we want to stop AIDS. So with that, thank you very much for your attention. And Agnes, I will turn over to you.
Thank you. Thank you so much. A huge thank you to our case presenters. I know it takes a while to prepare and put a good presentation together. So I really want to thank you for your cases. And if you can look in the chat box and Q&A, it's raised so many questions from others. So I'm hoping that everyone has had something that they can walk away with from today's cases. And we look forward to doing more of this. If you've missed the summary of the key takeaways, don't worry, we will be sharing this video and we will be sharing a slide or two with high-level key takeaways. And then lastly, to our expert panelists, you're amazing. Thank you. It was a very good comprehensive review of cases, and you left no stone unturned in terms of responding to our presenters. So thank you, everyone, and thank you for staying on late beyond time. And we'll see you at the next webinar. Thank you, everyone.
Thank you. Thank you, everyone.
Bye-bye.
Bye. Thank you, everyone. Thank you, Team Parker.
Bye.
Bye.
Thank you. Thank you. Thank you.
Yeah, thank you, Agnes. You did
Bye,
well.
everyone. Thank you, Dr. Fofi.
Yeah.
Bye, Agnes.
Bye. Bye, Vera.
Hoping to see you soon.
Bye.
Thank you, Agnes. Thank you, everyone.
Thank you.